It's now my pleasure to introduce today's presenter, Maureen Dobbins. Maureen is a professor in the School of Nursing at McMaster University. Her research focuses on understanding and on developing methods and tools to facilitate knowledge translation among public health decision makers. She's the Director of Health Evidence, which hosts an online registry containing synthesized evidence on the effectiveness of public health practices drawn from all relevant reviews published since 1985. She's also the Scientific Director of the National Collaborating Center for Methods and Tools, which offers leadership and expertise to help public health professionals translate research evidence into policy and practice. Maureen has kindly offered to speak to us today on how to integrate evidence-informed decision-making into organizational structures and processes, using examples from her experience working with public health departments across Canada over the past 2 decades. We look forward to her insights and advice. Welcome, Maureen.
Thank you so much, Diana. It's certainly my pleasure to be here today to talk to you a bit about what we've been doing with particularly the National Collaborating Center for Methods and Tools, and as well with the examples from health units. So I'm going to go through a few slides, and what I've learned over the years is sometimes it's more about the visuals. And so we seem to have this sense, certainly in the field of knowledge translation, that, or certainly in the early days, that if we build it, everyone will come. People will come if we disseminate research evidence in the right way to the right people at the right time. Then they will use it. And we've been learning along the way that it actually isn't necessarily as simple as that. And similar to this picture as well, that we seem to think if we can lead the horse to water that they'll drink. We can see here that that isn't necessarily the case. Or sometimes they don't even want to come with us to the water to get that drink that they might need. So I'm just going to tell you, a little bit more about, from an organizational perspective, then what else can we do? And it's less about individuals, but more, but really focusing on if we want to really change the way in which we make healthcare decisions, how can organizations really change the way in which they're working in order to support that? For those of you that might not be familiar with the National Collaborating Centers, there are 6 of us located across the country. You can see depicted here. So we're in Hamilton. There's the National Collaborating Center for Determinants of Health located at St. FX in Nova Scotia. We have the NCC for Healthy Public Policy located at the INSPQ in Quebec. We have an NCC for Infectious Diseases is in Winnipeg, and then 2 in British Columbia, 1 at up in Prince George is the NCC for Aboriginal Health, and then located at the BC CDC in Vancouver is the National Collaborating Center for Environmental Health. The centers have all been up and running for approximately 10 years. We're funded through till March 2017 with an overarching goal to assist the public health community in Canada to use the best available evidence in decision making. And specifically for the NCC-MT, which is our short name, the NCC for Methods and Tools, our vision is to guide the production and sharing and use of high quality evidence and for us to provide leadership and expertise in supporting both individuals and public health organizations in Canada to use the best available evidence in their practice. Some of you may be familiar with this model of evidence-informed decision-making in public health. It's there, as those of you that work in the field of knowledge translation or evidence-informed decision-making, you would be aware of many models and frameworks, theories that exist trying to explain knowledge translation. This one, which was originally developed by Dr. Brian Haynes, has now been further modified to be relevant for the public health community. But I really prefer this model to all the others because it, one, gets at the complexity of decision-making that we're faced with in the public health world. It depicts here that decision-making is made up of many different kinds of information, one of which we are sincerely hoping is the best available research evidence, but also the community health issues and local context and geography of our country, community and political preferences and actions, as well as the public health resources, both human and financial, that we have available to us in the services that we provide. And very specifically, we have public health expertise in the middle of this model, because it's that public health expertise that brings together the best available knowledge in all of these spheres, and then considers all of that information, likely in consultation with other stakeholders, to then make decisions, hopefully the best decisions for different jurisdictions, local jurisdictions. What isn't depicted in this model is how these different types of information may exert less or greater influence on different types of decisions. So here everything looks like it's all equally distributed in terms of the amount of influence, but in fact we know that's not necessarily the case. Sometimes the public health resources might exert the greatest influence, community or political preferences in other instances might. Sometimes it might be the research evidence. So this is really a model that's quite in flux. It changes from decision to decision. And what this model also allows is the flexibility that even if we were using across multiple jurisdictions the same best available research evidence, depending on the information that's gathered in these other spheres, then we may end up making different decisions depending on what we have knowledge in these other areas. So for example, what might work here in Hamilton when we consider the research evidence as well as all of the other spheres may not be the best service to implement or intervention to implement in another part of the country, so perhaps in a northern, rural, and remote area. So this model allows for that type of flexibility of taking into account all of this information in our decision making. At the NCCMT, we also use this model to frame what we do, and so this model is very much was chosen to be a circle to represent that there's no one place to start the process of evidence-informed decision making. Many times when we describe these 7 steps, we talk about starting with defining our issue, but in fact, it's very plausible that an organization may have evaluated its services, evaluated the progress towards achieving stated goals and objectives. They may have identified that they're perhaps falling short in a particular service area or particular interventions, and as a result, they now are starting to question, think maybe we should be doing something different, and now they might be into defining and then searching for the evidence. So this 7-step process of defining the issue, searching for the relevant evidence to answer that question, and in this case I'm talking specifically about research evidence, appraising that research evidence so that the best available can be used in decision making, synthesizing that evidence, and so it may be you find yourself in a situation where you may have a best practice guideline. There might also be a more recent systematic review that was completed or meta-analysis, and you may have come across some different single studies that have been published. You may also have some other epidemiological data from your local area. So there's many kinds of information that are being gathered that needs to be synthesized to come up with general suggestions, recommendations for practice. We then need to be thinking about whether or not the evidence that you have is applicable to the local setting, and whether or not any adaptations need to be made in order to be able to effectively and efficiently implement that service into practice. And then once we've made some decisions about what we want to do, we then need to be thinking about how are we going to effect change. If this requires a change in what health practitioners are doing, then how are we going to ensure that they all make that change and they're consistently doing that new practice? This may include also training, capacity development. So we need to have a plan to ensure that if we're moving to a new practice, that this new practice will actually occur and be sustained over time. And then finally, we want to evaluate. When we specifically think about evaluate at the NCCMT, we're thinking primarily about evaluating the implementation. So how do we know if we've actually changed practice? A little less focus on whether or not we're actually changing, let's say, a patient outcome, although that could still be part of this down the road, but initially wanting to make sure that whatever changes needed to happen at the practice level, that's happened. And that could also be rolled out to be thinking at an organizational level. If an organization is committing to consistently using and incorporating into its decision-making the use of the best available evidence, then what types of processes and mechanisms and infrastructure will need to be put in place to ensure that that happens. So some of the key issues that we've definitely seen in public health over the years can be divided into individual and organizational level factors. Certainly from the perspective of knowledge, skill, and capacity with respect to evidence-informed decision-making, what we in public health is particularly complicated in that most of the people that find themselves working in public health have not gone for specific undergraduate training in public health. We have very few school undergraduate degrees in public health. So therefore, the large majority of the workforce comes from a variety of undergraduate programs. So when we start to think about how to embed knowledge, skill, and capacity within the future public health professionals at that undergraduate level, the challenge becomes really quite large when we think about trying to affect change in many different undergraduate programs across many secondary institutions in Canada. While the NCCs are making connections with secondary institutions, you can imagine that this is a very large task. So the incoming or the future public health professionals are arriving with limited knowledge, skill, and capacity for evidence-informed decision-making. There, of course, are some enhancements happening with respect to the Masters of Public Health programs that exist across the country that have been up and running for a number of years now, with new ones, new MPH programs still being developed and opened up. But there's still overall within the workforce is varying levels of knowledge, skill, and capacity with respect to what I would call EIDM, evidence-informed decision-making. And then at the organizational level, context, culture, and infrastructure, we are seeing more recently more and more expectation being placed on public health units, public health organizations to be able to demonstrate their use of the best available evidence in decision-making. And this is certainly assisting in a change in the culture to be one that does recognize the value and importance of using evidence in decision-making, and definitely more interest in ensuring that the individuals within that organization have the knowledge and skill and capacity to practice in an evidence-informed way, as well as being able to demonstrate how decisions made about service delivery are evidence-informed. However, there's still across the country varying levels of importance exerted on EIDM in comparison to all of the other important and competing priorities that exist for public health. So how do you fit it all in? Certainly engaging in a process of changing one's culture and changing the organizational context is a very large task and something that takes many years to occur and many resources. So this competes with all of the other issues that public health deals with. So certainly culture is important. The context of understanding evidence-informed decision-making, and then certainly putting in place the infrastructure, the mechanisms, can definitely be issues that health units struggle with, and one of the things that the NCCMT is here to help with. From some of the work that we've done in the past, some of our research, if I had asked any of you to comment, you would have, I'm sure these would have come to mind. Time has always been a major issue in terms of being able to address integrating the use of evidence into practice. Even in this day and age, many organizations struggle with access to the available research evidence. So we have the help of a number of portals that exist now, and also through PubMed, at least we can search for evidence, the research evidence, but that doesn't mean that a health unit can always quickly get their hand on the full text article. Although that has improved over the last number of years, there are still challenges and a lot of variance across the country in what people have access to. There continue to be some limitations with respect to training and capacity for information seeking, as well as in critical appraisal skills. So once one gets their, has, let's say on their computer screen, research evidence related to their issue, how do they assess whether or not it's the best available evidence, or as I usually say, is good enough to inform their decision? So we know that skills continue to be lacking with respect to being able to quickly do critical appraisal so they can move on to the next step. And then, of course, lack of organizational support. So certainly there's, again, a lot of variation. There's some organizations that are very much on board, and right throughout the organization there's support for evidence-informed decision-making, and that varies quite a bit from organization to organization across the country. And so I really think about evidence-informed decision-making as sort of like an iceberg. The actual top part of, if we think of the top part, is that finding the evidence and appraising it and thinking about how we have to adapt it to be locally relevant. The really hard work is that piece that's underneath the water. That's the really hard part about putting evidence into practice. So some of the things that we've learned about keys to success at an organizational level for really committing to change, to consistently using research evidence in decision-making, is leadership and strategic direction. So from the very top of an organization, if you're CEO or president or medical officer of health, is a committed leader and mentor, champion, role model of evidence-informed decision-making, that is definitely important to success. And some of the health units that we've seen that have really made strides with evidence-informed decision-making have certainly identified a strategic goal as being one related to evidence-informed decision-making. So those two things together, where we actually have strong leadership that's committed, but also role models the use of evidence in decision-making, along with making it a strategic priority of the organization, seem to be two really important ingredients for success. Shared vision in terms of being able to then disseminate that vision of evidence-informed decision-making throughout the organization. And it's a really difficult task, and can be extremely difficult with large organizations that have multiple divisions, and then within divisions, multiple teams like we see in public health. Ensuring that everyone throughout that organization understands the strategic direction and understands what their role is a next really important task. In this day and age, we focus a lot on, or we connect with each other now more often in a virtual way than we actually do in face-to-face connections. And as it relates to evidence-informed decision-making, I strongly believe that developing face-to-face interaction and connections, relationship building is really, really important at all levels within the organization as well as with external stakeholders. And so really any opportunities that we can optimize for face-to-face interaction, I think, is really, really important. One of the things that we do here at the NCCMT is both individual and organizational assessments. So we can assess amongst the senior management team how they feel they're doing with respect to supporting evidence-informed decision-making. That type of a focus group amongst that senior management team can lead to the development of a plan. So they can identify where are the strengths that we can build on, as well as the areas in which they want to improve. And from that, we can look at short and long-term goals with respect to improvement that then provide an ability to be able to assess progress into the future. And then there's a variety of tools that are available now where public health professionals can assess their own individual skills with respect to evidence-informed decision-making. And then there's some specific tools that can help them to obtain any knowledge or skill that they may have identified that they need to improve on. With respect to the last two items, generally with knowledge translation, I often talk about we need to think carefully about tailoring our interventions, our knowledge translation interventions, to the specific needs of not only an organization, but then within that organization specific, again, divisions or departments, and then even more refined to the team level. So for example, in public health, we would have some public health professionals that spend the large majority of their day out in the community delivering services and spend very little time within the actual office, and therefore see their colleagues very infrequently. And there are other public health professionals that actually spend a much more greater proportion of their time in front of a computer in the office. So we would need different types of strategies in terms of capacity development, knowledge and skill development, as well as the development of culture and context in those different areas. And then finally, with respect to practice-based and relevant, many of the health units that we've worked with, we really focus on saying, identify an issue that the health unit is facing or the community is facing that needs a decision sometime in the next, let's say, 3 to 8 months. So there's actually an issue that requires looking to the evidence. We actually are waiting to act and making a decision from the findings of, let's say, a review of the evidence. So there's a real reason for doing this. It's important to the organization that this work be done, and there's action waiting to be taken. We found that that's really important for not making evidence-informed decision-making appear like an add-on or extra work, but actually trying to embed it within something that the health unit is working on. Just a few other comments that I'll make. We've learned over time that we can't just work at one level of the organization. So originally, in the early days of the National Collaborating Center for Methods and Tools, we were focusing on what individuals needed in an organization, what knowledge, skills, did attitudes need to change, those types of things. And we've now realized that you need to be working also with senior management at the same time to ensure that they're also committed to evidence-informed decision-making. At the same time that we also need to ensure that appropriate support mechanisms are there, infrastructure, and systems for how decisions are made are developed. There needs to be a lot of practice. I think sometimes we think, we can go off to a workshop. We may be there for 2, 3, or 4 days, and for example, like a systematic review workshop, and that we come home from that, and now we're off to the races to do our own review. But my sense is that we actually need to be able to practice our skills related to evidence-informed decision-making over and over and over again, and through mentoring, the development of those skills while we gradually take on more responsibility for making these changes in practice. So just some of the tools that I mentioned. So the organizational assessment, or assessing organizational needs, this comes from the Canadian Foundation for Healthcare Improvement. Many of you may have heard of this tool. It's called Is Research Working for You? And so we've used this tool. It's usually about a 2.5-hour focus group that, let's say, I might conduct with the senior management team. They all get the tool ahead of time. They go away and independently rate their organization on all these various domains, and then I bring them together in a focus group where they can discuss and try to come to consensus on what their vision is for their health unit. Something the NCCMT has created more recently is the core competency mapping tool. So the Public Health Agency of Canada has created a list of competencies for public health. A number of those are relevant to evidence-informed decision-making, and so the NCCMT created an online tool that allows someone to come on. They can search for, if they're interested in a particular competency, and when they click on that, you can see on the right-hand side of the slide here, it will list all of the resources we have at NCCMT that one could access to gain knowledge and skill in this sub-competency. We are now further expanding that tool. That tool was originally just mapped to NCC for methods and tools, and we're now working with the 5 other NCCs to map resources related to the core competencies across the resources that all 6 NCCs have. So this slide here just tells you a little bit more about the various tools that we have. We have a registry of methods and tools where we've searched the world for any resources that folks have been working on that are related to evidence-informed decision-making and knowledge translation. We have a very large country here in Canada, so we can't visit everybody and do all the learning and teaching face-to-face, so we have quite a wide variety of online learning products that are available. We do face-to-face workshops. We have different knowledge repositories that people can access. Diana mentioned one of them, which is Health Evidence. Another one is called Outbreak Health, which is a repository of evidence, both published and gray literature related to Ebola. We have a variety of multimedia resources, videos, and then we also have a knowledge brokering mentoring program and services that we provide. This is just telling you a little bit about our modules. We also have a series of search pyramids that identify by topic area different sources, freely available sources of information for different levels of evidence, let's say from guidelines to systematic reviews down to single studies. We created a few years ago a series of videos called Understanding Research Evidence videos, which is taking terms like odds ratios, relative risks, confidence intervals, forest plots, terms that over the years I and my colleagues had observed public health units struggled with in terms of understanding them, and we've tried to put them into interpretation and understanding of those terms in very layman's terms, and we have used cartooning of relevant and timely public health scenarios to explore the issues. And then finally, our in-person training program, which is the Knowledge Broker program, where we work with up to 5 public health organizations at one time over a 18-month to 2-year process, where we then train a cohort of 5 to 6 staff from each health unit, and they spend both face-to-face time with us here at McMaster, as well as monthly webinars and monthly support from our senior knowledge brokers over the course of this training period. We just a little bit here, we try to support the ongoing practicing of their skills with the monthly webinars by continuing to have them practice things like critical appraisal of different types of research evidence with us. So just in wrapping up, some of the things we've learned that are challenges to evidence-informed decision-making. The first one, many people don't know what they don't know. So with respect to evidence-informed decision-making, until they actually get a sense of how one might do decision-making differently, you don't necessarily know what you're missing, what you're not including. And so some of it is the messaging around what is evidence-informed decision-making and how is it different from maybe how current decisions are being made. Of course, time is an issue. Public health, like many areas, there's never a lack of other crises that crop up that may take time away from some of the work going on in evidence-informed decision-making, but how can we build that in so that EIDM initiatives aren't completely abandoned if there's a crisis that comes up. Management support is really, really key. So managers might not necessarily need to know how exactly to do, let's say, a rapid review, but they certainly need to understand it enough that they will understand the time implications for the staff that will be working on it and to be able to guide their staff through that process. Library services, some public health organizations have these services, not all of them do. And then it becomes an even bigger task to searching for the evidence. And also really just the last one there where progress is slow. When we're talking about making change in an organization, change oftentimes needs to happen in a slow manner, and it may appear sometimes as if progress is not being made. So we really need to be thinking about identifying small progress, what those indicators would look like, and to be communicating those and celebrating those. So I'm going to stop there, just that last slide, which is really about EIDM is, in my opinion, needs to be done in collaboration. It's very important that multiple stakeholders are all involved at different levels in the organization, and that we work together piece by piece in piecing together evidence-informed decision-making. So I'll stop there. Diana and Marshall.
Thank you, Maureen, for sharing with us your many valuable insights gained through years of dedicated effort in this area. Your firsthand experiences working with decision makers has really provided us with a greater appreciation for everything that is involved in evidence-informed decision-making in a public health setting, and bringing evidence to bear on policy in this context. Speaking of the attendees, it's now time to open up the floor to the webinar attendees for their questions, and I encourage them all to take advantage of Maureen's availability today to leverage her expertise by asking questions and seeking Maureen's advice on how to more effectively move health science evidence into public policy and practice. As we pointed out earlier, everyone is presently on mute, so to ask a question or join the discussion, you will need to use your control panel to either raise your hand virtually in order to speak or submit a written question, and we'll take your questions in the order that they're received. I'm going to jump in, Maureen, with the first question then. One of the things that you had a lengthy list of keys to success. Could you give us an example of an organization or a situation where this evidence-informed decision-making process has been very effectively implemented and give us some idea of what were the features of those keys to success that really played a major part, and what barriers or challenges did the group or organization have to overcome to realize the effective outcome or the positive outcome in light of all the challenges and pratfalls that you can hit in terms of this process.
Sure, thanks, Diana. So one of the organizations that NCCMT has worked closely with and who's made really notable strides as an organization with respect to EIDM is Peel Public Health. And Peel Public Health is just over 8 years into a 10-year strategic plan to changing itself to be consistently using the best available research evidence in decision making. So in terms of that slide where I was talking about keys to success, if we go back about 9 years, it started with the appointment of their medical officer of health, which was Dr. David Mowat. And David Mowat came to Peel Public Health as a strong advocate of evidence-informed decision-making. And so, in the very early days of this initiative, they had been doing some thinking about what their strategic goals will be, and they set a 10-year plan. Evidence-informed decision-making was one of 9 strategic goals identified in that 10-year plan. So one of the things that was really, really significant in that, one was in the naming of that as one of 9 priorities. 2 was in the timeline itself. So really the appreciation of transitioning into an organization that throughout the entire organization there would be a process that supported, facilitated, and ensured the use of the best available evidence in decision making, making that change at an organizational level, that would take a long time. So a 10-year plan was really, really important. In addition, over time, more and more resources were allocated, reallocated towards achieving that strategic goal. So it started small in terms of some smaller types of training that was implemented within the organization, and over time more resources were allocated towards that, and staff at all levels of the organization being involved in different types of training and mentorship and activities that happened. So all of those things were key. It was really, really important that the senior management team was on board with this, because everyone had to contribute really resources in the way of human resources, as well as there were financial implications. And the other part that was really key, well, there's many, many key parts. There's no one key that led to success. It was many things that happened. But the identification of some internal champions at different levels of the organization. So Dr. Megan Ward, Associate Medical Officer of Health at Peel, this became a major part of her portfolio in terms of leading the strategic change, and she applied and participated in the EXTRA program, so was an extra fellow, and embedded from that program that she was a part of, she created a number of internal structures and processes that really solidified evidence-informed decision-making. As well at other levels, there were also, Bev Bryant was identified as and given the role of Manager for Workforce Development that contributed to that. They allocated resources to having internal knowledge brokers, so a senior knowledge broker Lori Greco has been there for a number of years, and now they've been training additional knowledge brokers at the team level who then are supported by that senior knowledge broker. So many of those things came together. They've also done in-depth training. I believe now we just finished a week-long workshop at McMaster University last week on evidence-informed decision-making, and over the past 7 or 8 years, Peel Public Health has now spent, I think, about 160 staff to that training. And the final thing, I'll bring it back to David Mowat. You know, while he was the medical officer of health at Peel Public Health and being a champion for this initiative, he also became very involved in the process himself, in that if someone at the team level had suggestions for public health services, so for the provision of interventions for public health services, many times they became involved in conducting a rapid review. Then they would do an assessment of the applicability of any recommendations that came out of a rapid review. And then those frontline staff would have a meeting with David to look at their report. He would read those reports very carefully. He would question staff, challenge staff. He'd want to know what the evidence is. He himself loves reading the evidence and thinking about interpretation and how it's applicable. And so the frontline staff actually were able to observe themselves in real time with David how he would consider the use of that evidence in practice. And I'm sure meeting with the MOH, particularly at the beginning, likely was may have been stressful for staff, but I think over time they really valued that effort and that interaction with the medical officer of health, where he was really able to demonstrate his commitment. Definitely was a key to moving this organization forward.
Okay, well, thank you. I've got 5 questions that have been submitted, all in written form. So I'll go through them in the order they were received, and I offer a blanket apology for any name mispronunciations I might commit. And I'll start with the question from Namit Sharma, who asks, is there a training opportunity available in your mentoring program? What are the eligibility criteria?
Great question, so thank you for that. Eligibility criteria, well, at this point, we've been focusing on public health units in Canada. So, I mean, that is our primary target audience with the National Collaborating Centre. Because I think I may have missed before, I hope I didn't miss saying that we're funded by the Public Health Agency of Canada. All of the centres are. And so our primary target audience is public health organizations in Canada, and also that organization needs to, I guess the eligibility needs to be that they agree to what the program is and what they need to, what an organization needs to do in order to support the program. So we end up signing contracts with the organizations that participate, which indicate that the organization is will undergo an organizational assessment at the senior management level to assess strengths and areas for growth with respect to evidence-informed decision-making, that they will identify 5 to 6 staff that will participate in the training program with us, that they will provide, they will commit to giving those staff the time away from the office to attend 10 face-to-face workshop days with us here in Hamilton. So that starts off with a 5-day workshop. 6 months later, they come back for 3 more days, and 6 months after that, they come back for 2 more days. In between the face-to-face workshop days, the organization will commit to their staff attending monthly webinars that are 90 minutes in length, as well as to a monthly follow-up call, which is usually about an hour in length, with a senior knowledge translation or knowledge broker. As well, the organizations also commit these 5 to 6 staff to have 2 hours every week throughout the entire mentoring program to continue practicing their skills and working together as a group. The organizations also contribute financially to the running of the program, so it doesn't cover all of the costs of this program, but it contributes to the cost. And then in the final 4 months, the staff actually conduct a rapid review, and so the organization is committing to identifying a topic for which the rapid review will be done and continuing to give the staff the time in order to be able to complete that rapid review. The mentoring program, as I said, lasts about 18 months to 20 months-ish. So we only have the capacity to run 1 cohort at a time. So the first cohort began in January 2015, and just ended in December of 2016. And we just started our new actually it might have been 14. We just started a new cohort in January, so they're not quite 6 months in now. When we put out our call for interested organizations, we actually were really pleasantly surprised at the amount of interest that there was, and we only can take about 5 organizations for each cohort at this time.
Okay, thank you, Maureen. Marshall, another question?
Yes, the next comes from Bastien Moineau, who asks, how do you make the teams accept that their day-to-day practice is not up-to-date or not optimal?
Yeah, so that's a really good question, and you know, there's no easy answers, I think, to those of us who work in this field. You know, one of the things that I talk about is somehow we need to get to a point where we're, as practitioners, we should be thinking that our practice should constantly be being changed in some way. That the knowledge upon which we base our practice, so research is constantly changing, new evidence is always emerging, and that along the way, as we learn more and gather more information from research, there may be things that become identified that maybe we could be, maybe we're not being as effective with our interventions as we're really hoping we would be, and therefore we need to be thinking about what else we could be doing so that we are offering the most effective and efficient services. So, you know, I think first we need to have in place mechanisms that allow us to evaluate the impact of the services that we're providing, to be able to feed that back at a team level in terms of this is how we're doing, how does this compare to where we were hoping to be, and then from there we can be also identifying if there's a gap there, you know, maybe there's some other things that we could be doing and we should be considering those. I think it's important to really encourage individuals to be, you know, critical of, I don't mean critical in a negative way, but actually questioning practice. So why are we doing this the way we're doing it? How do we know that it's the best that we can be doing, and what else could we be doing? So, you know, really encouraging that that way of thinking in our staff. And I'll just end off there by saying, what we also need to be very sensitive to is that, you know, any change in practice, particularly ones that maybe we've done for a long time, we do need to be sensitive about that. You know, as not only health professionals, but many of us, we come to work every day hoping we're doing good things and making a difference. And oftentimes in the interventions and programs we may have been delivering, we may never have actually observed that they aren't useful and helpful and having positive effects. We might not be able to identify a specific outcome, but I'm sure it would be, we go home at the end of the day hoping that we've affected positive change. So if someone comes around then and says, you know, what you've been doing, the research tells us isn't effective now, we need to be prepared to deal with the emotional side of that. And that's an area for which I think we may not have been really focused as much as on, whether that's at an individual level and even at a team level or an organizational level. We need to be cognizant of the fact that people are emotionally tied to some of the interventions that they do, and that if we want them to be doing different things, we need to be able to address those emotions as well.
Thank you. Marshall?
Iva Chung is the next questioner, and her statement and question are, thank you for your informative presentation, Dr. Dobbins. In my own research, we've successfully brought researchers, practitioners, and patient partners together, but we always seem to have trouble bringing policymakers to the table. What are some strategies to encourage policymaker participation and buy-in?
Yeah, so I guess that's the million-dollar question, and we'd probably all love to have John Lavis on the call right now and to give us his insights too around policymakers. You know, this is probably a little bit more hypothetical on my part, but I think in being able to identify what are really important issues to policymakers' constituents may go a long way in a particular event being important enough for politicians or for those policymakers to be present. So certainly those important issues, I think the more we can get constituents involved in voicing what's important to them to politicians, and then therefore other policymakers that are helping to inform what politicians are doing, can certainly help motivate that sector being at the table. So I think I'm going to stop there. There's probably some other tips. I think there's probably others, like I said, John Lavis, who work exclusively, or not exclusively, but a lot with policymakers who would have other comments to say on that. But I think in demonstrating how important this is to the community are some of the things that perhaps we could focus our communication efforts on ensuring those messages are getting through.
Thank you, Maureen. Marshall, additional questions?
Yes, the next question's from William Kennedy, who wrote, one of the issues I see in having knowledge-based decision-making that is variable based on location and management is that there may be issues in maintaining consistency between organizations that talk to each other, as well as staff movement. How do we account for these moving forward?
Yeah, that's a great question, really. And to me, it comes back to really in the definition of evidence-informed decision-making. And when we think about the components of that definition that talk about the use of the best available research evidence along with the local context and community and political preferences and resources, all of those things coming together. If we really think about what that definition means, that to me that definition implies that we may have some differences that may exist. Now, I usually say my best answer for everything related to EIDM is it depends, and I think that totally applies here. And it may be that in public health, when we think about 36 local health departments in Ontario alone that all have different to some extent varying levels of characteristics related to different health outcomes. It's not constant across the province in terms of issues that different local jurisdictions face. So, that definition of evidence-informed decision-making allows us to think about, here in Hamilton, what are our major issues? What are the things that are the priorities for public health that are based on the various factors of the population that live here and the other types of factors that are relevant to living in Hamilton? Those are different if you are working in the Temiskaming Health Unit, which is 6 hours north of here, small, very small, somewhat remote area. I think we do need a system that would, like a decision-making system that would say, there may be very different issues that they're faced with in the Temiskaming Health Unit that they need to focus on, and maybe different ways in which they need to implement their programs that may not be relevant here in Hamilton. And so to me, it's not about, it needs to be the same across all jurisdictions, but rather we need to be able to talk about what does evidence-informed decision-making really mean, so that someone can make sense of the fact that something they might be doing here in Hamilton, they might not really do or do in the same way in Temiskaming Health Unit. So it's more about explaining that. And, in this particular example, this might be more relevant when we're talking about public health related factors than if we were talking about, wait times for knee replacement, those other types of healthcare important issues. So I think we need to really consider the context and the area in which we're working, and we just need to be able to better explain what it is we mean by EIDM.
Well, thank you very much, Maureen. I know we have other questions, and I apologize to those of you whose questions were not answered within the hour, but we're running to the end of our time frame, and I'd like to thank Maureen for this extremely informative session. Thanks also to all of our webinar participants for attending and your thoughtful questions and contributions to this interesting discussion.